So my talk today is on the role of SPECT CT it has in managing various wrist problems. And as you know, wrist is one of the most complex joints in the body, and more so because very small structures and many joints. And on top of that, the complex biomechanics that go with it make it quite difficult for the clinician to actually identify the source of pain. And when the identification of source of pain becomes difficult, trying to image it, trying to find it could be a needle in a haystack in some cases. It also presents a significant economic burden. So therefore, all in all, managing wrist pain makes it a very challenging clinical conundrum. So a good history and a physical examination should identify most of the causes of wrist pain, but obviously the clinician has to then decide whether this is bone originating pain or is it a soft tissue originating pain, and then subsequently send them to respective imaging modalities, i.e. for soft tissue problems, ultrasound would be the modality of choice. And then, as you can see, bone scan plays quite a central role in the management of these patients. Although, if you go on the American College of Radiology website and look up the appropriateness criteria for imaging in wrist pain, you would find bone scan pretty much not figure in many of those indications. But I think bone scan would play a very important role, particularly in directing what other investigations one might choose to use, be it MRI, CT. That was the previous, this algorithm was developed much before SPECT CT came into being. So the bone scintigraphy, the usual, the plus points are that it's highly sensitive and therefore able to detect most of the problems, but because of the lack of clear anatomical definition, the specificity is lacking, and of course the radiation exposure side of things is always something which is put forward as a negative quality. So the next step was to improve on the bone scintigraphy, was to say combine it with X-ray. So you have a planar bone scintigram of the wrist, and then you combine it with X-ray. You could either look at side by side, or you could use registration techniques using markers, which we've done in the past, co-registration study, and published it. So we did a study in 2001, 35 patients we looked at, and we found that when you looked at bone scans alone, and when you looked at the X-rays alone, and then looked at the incremental benefit of what combining both the bone scan and the planar bone scan and the X-ray was. And we found that in about 50% of these patients, there was an incremental benefit on adding the X-ray or anatomical localization derived from the X-ray onto the bone scan. But bone scan still remains quite sensitive. So here is a planar scintigram showing the area of uptake within the wrist. Where is this? And here is an X-ray. It's quite difficult to say where it is in this complex anatomy. So when you do a co-registration, then you can see that this is between the lunate and the capitate bone. That's the degenerative disease there. And then following on from that, Gross et al. Looked at combining SPECT with CT. But however, this is manual co-registration of the technique, so you had to use softwares to try and co-register CTs, which are acquired at a different time point, along with SPECT, which are acquired at another time point. Again, it proved to be an incremental benefit over just the anatomical co-registration with an X-ray and bone scan. But however, the problem still remained. So when you acquire scans at different time points, are we looking at the same physiology? So obviously there's a difference in physiology. It could be, of course, the patient position, and then movement issues, and then of course the software issues in trying to handle this. And It's always manual registration. You're trying to register something on a scintigram, which we've always said is an unclear image with a crystal clear anatomical image on a CT. So obviously, SPECT CT would probably provide the best answer here then. It combines anatomy with function elegantly in a single sitting for the patient. So from patient convenience point of view, excellent. So patient does not have to run back and forth for various techniques. And of course, it may prove to be cost effective to the system, of course, because you're trying to answer it in one sitting rather than having to come back for various other techniques. And there is increasing evidence for this. About 961 articles when I looked up yesterday night that have been published on the role of SPECT CT in various indications. So how do we do it? So we say this is the Superman position. The patient has got one arm stretched out. And this is for patients who've got problems with one arm. Of course, when there are patients who've got bilateral problems, then you've got Superman with two arms in front. Also, we always look at the planar image to try and see if there are problems in the other hand which may need further investigation. So if we do find that there are incidentally areas of increased uptake in the other arm, we do include that in our field of view. These are the SPECT acquisition parameters, and these are the localization CT acquisition parameters. Now, the other debate is, what do we use for these patients? Do we use just localization, i.e. good enough CTs that can also do some attenuation correction, or do we use diagnostic quality CTs? Of course, we're dealing with extremities, so the question of radiation dose becomes a bit irrelevant in this case. So therefore, when you want to have the best anatomical delineation and trying to get the best out of the system, I think using a proper diagnostic CT would be much advised. As you can see, the slice thickness is much better, which would allow the musculoskeletal radiologist to look at the CT in detail and try and pick out other problems that might be in addition to the boring problems that we see. So in our center, we do it as a joint reporting session. The nucleomed physician, whoever is on for the day, looks at the images first and reports it. And then we have our resident MSK radiologist who comes in, and then we sit together, look at the images before giving the final report. And that way we have found that we get the best out of the system. So here are some cases. So a patient who had a fall on the outstretched arm, and pain in the ulnar aspect of the arm. Where is this area of uptake? This is this is the delayed images, this is the early blood pool images, vascular on the early blood pool images, most likely representing a traumatic etiology on SPECT. As you can see, it's a blob amidst nowhere. And on the CT, as you can see, it corresponds nicely to hook of hamate fracture. It's quite good and much easier now for us to say this is where the problem is, and for the clinician it's a clear-cut diagnosis made. Next patient who had a recent injury and continuing pain. What was the reason for the continuing pain? As you can see on the early blood pool images, there is slightly increased vascularity with marked increased uptake on the delayed images. And again, on the SPECT images, the uptake corresponds to the first MCP joint there, a carpometabolism CMC joint. And on the CT images, as you can see, there is a cyst within the scapula. Now, is that the problem, or in fact, the problem epicenter lies slightly higher up, where there is a subluxed first metacarpal. So that following the traumatic event, there is a subluxation, and therefore, in association with the soft tissue, there is a bony reaction as well that you're seeing, which is the reason for the pain. Another patient had, again, pain in the left wrist with increased focal uptake on the delayed image and early vascular increase. You can see that this patient had a diagnosis of scaphoid fracture done long before, so there's continuing pain. So the question was, has the scaphoid fracture united or not? And you can see that, the uptake corresponds nicely to the fracture of the scaphoid, but the fracture has not united completely. And in fact, it has resulted in subarthrosis. So the management is completely different here, so they would have to go in and probably our orthopedic colleagues would be able to answer that much better. And then a further patient who had, once again, we seem to get a lot of left-sided problems. Almost all of my cases seem to be left-sided. Anyway, this patient had uptake in the radial aspect. Now, one of the problems which we have found is, even with SPECT CT being done in a single setting, the problems of movement still remain. Now, the reason being, with the CT image is acquired within a minute, but the SPECT image is acquired over 20 to 25 minutes. So, even with the best of techniques to try and immobilize the wrist, there is a little bit of laxity that happens over the period of time. So when that happens, as you can see here, there is some misregistration that occurs. So you will have to try and correct for that, and software allowing that can be done. As you can see here, it appears as though it is within the joint structure there, but on the CT study, the joints look absolutely pristine. So, you're thinking, what is the reason for this? So when you try and realign the pictures, and this is a much better registration, as you can see, the uptake now corresponds to the scaphoid, and our musculoskeletal radiologist confirms that this is a fracture of the tubercle of the scaphoid. And with the SPECT CT, we're now having to come out of our comfort zones, making new diagnoses. So in this patient, luckily this is in the right hand, had pain in the ulnar side of the wrist. Nothing much on any examination, so they said, let's try SPECT CT. As you can see, it's very hot on the delayed images and very focal on the SPECT images, but it corresponds to the ulnar carpal joint. On the CT, there is nothing much except for the fact there's an ulnar variance, and again, MSK radiologists will eloquently describe as to how the biomechanics alter because of this, and therefore that's the site of the origin of pain. So again, as I said, we are drawn out of our comfort zones to try and make these kinds of diagnoses, like ulnar abutment in this case. So we looked at about 31 patients, that were done previously in our institution, and look at the impact SPECT CT had on the evaluation and further management. And we found that in about 80+% of these cases, SPECT CT provided additional information, mainly because of the improved localization and, of course, characterization of these lesions. And additional new abnormalities were found in about 40% of these patients, and nearly 60% of these patients, our orthopedician confirms that the management was changed following the report from the SPECT CT study. And of course, always the holy grail for most musculoskeletal imaging has been MRI. And you have to compare your technique against how it does against MRI. And our colleagues in the Churn have recently looked at and compared the effectiveness of SPECT CT as opposed to MRI in about 21 patients in a pilot study. And they found that MR is highly sensitive, much better than, of course, SPECT CT, but its specificity was lagging, just like bone scan specificity was lagging previously. They found that SPECT CT had a much higher sensitivity compared to the MR, and therefore the two would be a good complementary solution. So to summarize, imaging reasons for wrist pain remains a challenge, of course. SPECT CT, as I described in the algorithm, where bone scintigraphy had been at the center of trying to direct the physician into which direction to go. SPECT CT, I think, would have a very central role in in diagnosis and management of these patients. Of course, teamwork is core to any success. Thanks all our nuclear medicine team, TSTT, and of course, our schools, radiologists. Thank you.